On the 7th of July 2005, terrorists targeted the heart of London's transport system during the peak morning rush hour. 3 bombs were detonated on the Underground rail system at 8:49 within 50 seconds of each other. A fourth bomb 58 minutes later exploded above ground on a double-decker bus. There were a total of 56 deaths, including the 4 perpetrators. There were 775 injured. 53 of the deaths were at the scene. Survivors at the 3 blasts on the subway began evacuating from both ends of the tunnels, creating 6 areas victims gathered, which led to confusion about the number of blast sites. At the time, the only people fully aware of what had happened were the survivors on the train. Communication with the survivors was hindered due to poor mobile phone coverage underground. The first blast exploded on the Circle line between Liverpool Street and Aldgate Tube Station. That blast killed 7. The second blast was also on the Circle line westbound, having just departed Edgware Road towards Paddington Station. This particular line had 2 parallel tracks, making it relatively wide, which made the blast less destructive as the force of the blast was dissipated along the wider tunnel. 6 people lost their lives. The third blast on the Piccadilly line occurred between King's Cross and Russell Square. This line is much narrower, only 3.5 metres wide. There is just 15 centimetres clearance to the outside of the train. The blast force on this train was reflected and concentrated. 26 people perished here. Further complications were encountered as the only airflow through the tunnels is created by moving trains. When the train stopped, the airflow also stopped. Temperatures reached 60 degrees, asbestos cement was damaged, requiring regular CO2 monitoring for the recovery teams and the survivors on the platform. The final blast occurred at 9:47 a.m. above ground on the number 30 bus at Tavistock Square. It had arrived at Euston Bus Station at 9:35, where people had been evacuating the underground tunnels and boarding buses to leave the immediate danger area. At the scene, disaster triage had been implemented using simplified priority 1 to 4 tagging system. 775 people were injured in the bombings. 53 people died at the scene and 3 people died in hospital. Of the 775, 55 were categorized P12 and described as immediate threat to life or critically injured. 667 were tagged P3 or walking wounded, and 2 patients were assigned P4, which was expectant or died at the scene. The London-wide major incident was declared at 9:23, and the Royal London Hospital declared a major incident at 9:26, just 35 minutes after the explosions. The first of the walking wounded arrived in the department 4 minutes later at 9:30. The first critically injured Cat 1-2 patient arrived at 10:05. The Royal London Hospital was able to implement the emergency department disaster protocol and decant the department in less than 30 minutes. They did this by admitting patients already in the department and asking those well enough to leave to present to the general practitioner. In other areas of the hospital, surge protocol was being implemented. All elective theatre was cancelled and the hospital freed 100 beds in 30 minutes. PACU had also been upgraded to expand ICU. The first patient arrived at Royal London Hospital privately at 9:30 as a P3. 27 of the 55 P12 patients were transferred to the Royal London Hospital, arriving at 10:05. And of the 667 P3 patients, Royal London Hospital received 167. The Royal London Hospital Emergency Department is geographically close to the King's Cross Station and Aldgate. It has 5 trauma bays equipped with overhead gantry, dedicated ultrasound, and 2 CT scanners. The Royal London Hospital Emergency Department reached capacity for resus patients within 15 minutes. Most of the patients had arrived within 2.5 hours of the blast. On arrival, patients were re-triaged. 8 patients required full trauma teams in resus rooms. The other 19 patients were allocated acute cubicles with 1 doctor and 1 nurse treating each patient. P3 patients were managed in areas of the hospital close to but not inside the emergency department. The main focus during the surge period was rapid assessment and movement to definitive care. Heavy reliance on ultrasound in resuscitation rooms helped limit unnecessary CT resulting in the most urgent scans being performed in a timely manner. Only 6 CT scans were performed during the initial surge phase for patients needing assessment of traumatic brain injuries. Royal London Hospital requested 1,455 units of blood components, although the actual number of blood components transfused was 440 from triage to discharge. 246 units in the first 15 hours. Hospital liaison managers were present on each of the 3 London blood service sites to facilitate communication and reprioritise delivery of blood components. Effective decanting of the department and creating of over 100 beds in the hospital meant that even though the resuscitation bays had reached capacity in 15 minutes, at no stage was the capacity of the resuscitation area exceeded. Decanting of ICU by inter-hospital transfer, opening closed ICU beds, and discharging patients to the ward under the care of ICU outreach teams meant that ICU were able to admit all 7 of the major incident patients with a peak admission surge rate of 2 patients per hour. Part of the London Mass Fatality Plan included deployment of medical officers to the site to triage and commence treatment. Treating P3 victims at the site reduces the number of victims being transported to the hospitals, which also eases surge numbers, which have the potential to overwhelm hospital resources. It also prioritises the critically injured for transport. A portion of the P3 victims were transported to a nearby hotel and treated at the hotel. As the number of fatalities grew, it was apparent that existing mortuary facilities would not be able to cope with receiving the deceased. Within 24 hours, a temporary mortuary was established. The facility included 4 separate reception and storage areas and individually allocated to 4 bomb sites so as not to cross-contaminate scenes. Viewing areas, photography, radiology, assessment areas, as well as staff facilities were also available. The families of the deceased made special comment on the temporary mortuary, allowing them to spend between 2 and 8 hours with the victims and having access to on-site family liaison officers and faith leaders for support. The disaster plan was able to maintain sensitivity in a distressful time. Radiology resources were allocated extremely well. CT imaging especially was able to be reserved primarily due to heavy reliance on focused assessment with sonography in trauma, fast scanning. This allowed the department to avoid bottlenecking at the CT, and all traumatic head injuries were scanned immediately. In the following 7 days, 18 CT scans were performed, primarily for radiological spinal clearance. A significant backlog of imaging had developed, and it did require extra staff to clear in the following days, this highlighting the effective prioritisation of radiological resources. Emergency blood requested in the initial phase was 1,455. The actual number of blood components transfused was 440, which included all units from triage to discharge. With the assistance of hospital liaison managers on site at the blood banks, demand was met without depleting stock. Deliveries were made by emergency lit vehicles, and despite heavy restrictions in the city, no delays were reported. Literature was not available for individual demand and supply for separate hospitals. However, the evidence does suggest that all the hospital request numbers far outweigh actual transfused numbers without depleting existing stock. One major receiving hospital ordered no emergency blood on the day and was able to manage with existing stock only. Brisbane's inner city has been the target of a terrorist attack this morning at 8:49. 4 explosions in Fortitude Valley, Central Station, South Brisbane Station, and the South Brisbane Busway have injured several hundreds of people, with at least 50 confirmed dead. Emergency services have been activated. If Brisbane were to be targeted in an attack similar to the bombings in London in 2005, we would anticipate 27 P12 victims requiring immediate medical attention and 167 P3 patients or walking wounded. The PA emergency department is very similar to the Royal London Hospital with 5 resus bays, X-ray machines, and 1 CT machine with direct access from the trauma bays, and 25 acute beds. The Emergency Department Code Brown Local Plan, the EDCB-LP, outlines specific resources available on a normal rostered shift with 8 staff allocated in the acute area. This nurse-to-patient ratio in the 25-bed acute area is 1:3 with 1 allocation at 1:4. The acuity that can be expected in this situation is going to be high. The 27 P12 patients should be triaged at the scene as quickly as possible and transported to the ED. The patients will be re-triaged at the PAH using the ATS as per the EDCB-LP. 8 of those will need to be seen in the resuscitation bays, and the remaining 19 patients will be allocated into the acute area. With even distribution between 8 acute nurses, the nurse-to-patient ratio becomes 5 staff with 1:2 and 3 staff with 1:3. This is 3 nurses receiving 9 traumas. When you consider that the primary goal of the site medical team is to evacuate and transport quickly, resulting in a large number of patients arriving at the hospital rapidly, noting the peak surge rate of arrival in London was 18 per hour, 1 nurse into 3 patients can easily be considered an unsafe workload allocation. Furthermore, in the resuscitation area, the nursing allocation is 4 staff to 5 bays, leaving 1 entire trauma area without any nursing staff at all. Interesting, in the EDCB-LP, there is a higher number of medical officers on the floor than nursing staff, with 10 doctors treating in acute and 5 in resuscitation. The EDCB-LP allocates only 2 staff for the role of site medical commander, filled by a consultant, and site medical team, filled by a registrar or clinical nurse. The London Major Incident Plan provided at least 2 doctors at each scene to work alongside senior ambulance officers. They provided formal medical presence and commenced treatment at the site. With the assistance of other ambulance officers and doctors attending the scene, approximately 350 of the 700 victims were treated at the scene, with the other 350 victims transported to other hospitals for treatment. Considering the success of the site medical teams in London being able to triage appropriately and commence treatment at the site, and subsequently reducing the surge numbers arriving at the hospital, this ability to decrease the surge numbers arriving in the ED would ease the burden on the staff at this hospital that has already been highlighted as potentially unsafe. This has a large amount of potential for expansion and providing greater good with more allocated staff. Another proposed recommendation to improve local management would be implement strict protocol for the use of fast scanning in the department. While in London 2 CT scanners were available, which makes it more important to prioritise the most urgent scans, as the PAED department only has 1. These scans could be in the resuscitation rooms as well as the acute area, with 3 mobile ultrasound scanning devices where all patients have been exposed to a blast with unknown injuries. By utilising the fast scan and reducing the number of CT scans required during the initial search period, this reduces the risk of bottlenecking flow through the department. Once the initial surge period is managed, non-life-threatening injuries can be imaged and managed safely.